I am a biologist and a researcher, and for the last 13 years I've been working in San Donato Hospital. I've been in charge for the point of care testing of coagulation, and in particular in cardiac surgery and in the intensive care unit. And I'm very happy to be here today to speak about the platelet contribution to clot stiffness assessed by the Quantra, because a lot of my research over the past years actually has been focused on platelets. So when it comes to platelets and testing of their function, I'm sure that many of you are aware how much effort has been spent over the last decade and more addressing the first 2 points of this list. And I can say that we got very good results, both in assessing the efficacy of the antiplatelet therapy and its residual effect when it's time to discontinue and go to surgery. But framing the platelet function in the context of the postoperative bleeding, so we can put it in the bleeding management algorithms that we all love so much, is our present challenge. And many projects, including one from our group, are looking for an association, a specific cutoff value in the general population of patients undergoing cardiac surgery or other kind of high-risk operations, measuring specifically platelet function, failed the attempt, finding no association or numbers with very low positive predictive values. And so a suspicion is that given the multifactorial nature of the postoperative bleeding, maybe we are looking at something too specific. Perhaps we need a more comprehensive platelet-related parameter. So maybe it's both platelet count and function. Of course, both count and function are heavily affected during the cardiopulmonary bypass in cardiac surgery for a number of reasons. And platelets bind to the protein-lined circuit. They are activated by the increased shear stress of the CPB. They suffer low temperatures. Of course, they are lost by the intraoperative bleeding itself. These times are time-related, longer the run, heavier the losses, and the function exhaustion. At some point, some of them could be temporary and at least partially recover some time after surgery. So is it possible for us, this is a question, to capture all this in one platelet-related parameter? As I've previously said, maybe the platelet function alone is just one piece of the whole picture. So after spending years working with the impedance aggregometry, that is multiplate and Rotem platelet, that specifically assess platelet aggregation in response to specific agonists directed against specific receptors of our interest, we turned our attention to the viscoelastic. And you all know that the viscoelastic devices, Rotem for instance, measure the clot firmness with the amplitude of the curve in millimeters. And from the overall clot firmness, you can calculate the platelet-related firmness just as a difference between the XM maximum clot firmness and the FIPTEM maximum clot firmness. But viscoelastic devices measure the viscoelasticity of the growing clot, and the amplitude is not elasticity. In the green box here, you can see that with mathematical equations, from the amplitude, we can obtain both the elasticity and the shear modulus parameters. Quantra, on the contrary, measures and displays the shear modulus directly. And so when it comes to the practice, these values all the same, it's just number changing. And the answer is no. And when you look at this paper, and when you look at the relationship between the amplitude, the elasticity, the shear modulus, you can clearly see that the association is not linear. This means that small differences in millimeters of amplitude could bring to large differences in clot elasticity. And this is further illustrated here in the table on the right. And here the platelet-related clot firmness does not change at different platelet counts due to different fibrinogen contributions, but platelet-related elasticity does, and greatly. And now this is a platelet about theoretical calculation. And the question is this true for real life patients? So some years after this first paper, we applied this reasoning to a large population of real cardiac surgery patients in which we had, together with ROTEM, EXTEM, and FIPTEM assessments, also an ADP test on multiplate for the direct measure of the platelet function. And the picture on the left confirms that the association between the platelet-related amplitude and elasticity is non-linear. And then we tested the amplitude and the elasticity for the predictive ability of a poor platelet count and or function, where the poor was settled at the lowest quintile of the distribution, that is 100,000 platelets for microliter of count and an ADP of 12 units for the function. That's very low. You can see that elasticity performs significantly better than amplitude. And when you test the correlation of elasticity and amplitude specifically against count and function, once again, you can see that platelet-related elasticity shows much better parameters of associations and amplitude. Given these results, these numbers, the conclusion is easy to come. And difference in elasticity should replace difference in amplitude as a parameter of the platelet-related clot firmness. So this paper was published, as you can see, in the very beginning of the 2020, and you all know what came after that. So we are now looking forward to see if the manufacturers of the viscoelastic devices involved would receive and transpose this message into reality. After all, it's just soft. Here comes the Quantra and its direct assessment of the shear modulus for the overall clot firmness and its specific platelet contribution. And that was the reason why we so intrigued to try it in cardiac surgery in our institution. So in 2018, we set a small study of 30 patients that we tested with Quantra, ROTEM, and multiplate, together with standard coagulation, before and after cardiac surgery. Any kind of patient, any kind of cardiac surgery. The endpoint here was cautious, not clinical, just the comparison of the Quantra with the other viscoelastic devices. But the results ended up in something to a certain extent unexpected. That is that the Quantra PCS, the platelet contribution to clot stiffness parameter, incorporated both platelet count and function. Let's see this in detail. When you put the PCS against platelet count on the graph, you can see a strong correlation between them, and that was expected. What was not is a moderate but independent association between PCS and ADP-related function that you can see on the right. And the association remains significant even after adjustment for the platelet count. And here just one clinical case showing you an example of how PCS is sensitive to variation of platelet function. A patient operated with Bentall surgery received, after protamine administration, desmopressin that increased the PCS parameter by a couple of hectopascals. Now, we already knew it from multiplate that desmopressin was able to increase platelet adhesion rather than aggregation, but in a way probably that the device was sensitive to it. And now we know that Quantra can see the same effect too. Another clinical case illustrates what happens during COVID. In March of 2020, in our institution, we were the first to point out that COVID was a prothrombotic condition. And we show it by using the Quantra device, because we don't know how dangerous the blood from COVID patient was. And we used Quantra because it was a completely closed system. And COVID is a prothrombotic condition because of the enormous production of fibrinogen and huge involvement of platelets, at least at the beginning of the disease progression, maybe determining the deleterious effect of the COVID on some patients. And the numbers of platelet count and fibrinogen dosing and the numbers on the Quantra monitor here talks by themselves. Now, among the limitations of our first study on the Quantra, there was a low number of patients under the effect of antiplatelet therapy. Including this kind of patients seemed the right way to investigate to what degree the PCS incorporates the platelet function. So we decided to set a study specifically on patients who discontinued antiplatelet therapy and underwent cardiac surgery on low platelet function. This study enrolled 50 patients, and the endpoint this time was clinical, the prediction of measured bleeding as defined by the class 2 or higher of the universal definition of perioperative bleeding. That is bleeding higher than 800 milliliters in the first 12 hours after surgery, and or transfusion of platelet concentrates, and or surgical reexploration. The devices used were the same as the first study, the Quantra, the Rotem, and the multiplate, and we calculated also the platelet component and the platelet component at 10 minutes for the Rotem. And the study is now closed. The manuscript has been submitted to a peer-reviewed journal, is under revision, so fingers crossed, because we believe that the results of the study are very nice. The Quantra PCS parameter has the best ability to discriminate the measured bleeding with a positive predictive value of 85%. Follows the Rotem platelet-related A10, but there you lost almost 20% of the positive predictive value. And the third place goes to the platelet count. The good news for centers without point-of-care testing, if only they can have their platelet count with a quick turnaround time. And the ADP test is off the podium because of the low positive predictive value. And we already knew that from our platform studies that enrolled more than 500 patients with pre-op and post-operative platelet function testing, and that achieved a PPV of just 35%. And here it's more or less the same. Now, coming back to where I began the talk, what we are looking for when studying platelets and bleeding is the numbers that trigger platelet transfusion. Probably it's the last gray zone in the existing algorithms for bleeding management. This number we are looking for must have a high positive predictive value. And because, putting it simple, this means that giving the therapy for values below the threshold brings you a low probability to be wrong. And coupling to it with a good negative predictive value, meaning that not giving the therapy for values above the threshold, you have a low probability to be wrong. That's bingo. We got exactly what we were looking for. Of course, a word of caution is absolutely necessary here. We have chosen a high-risk population, and we've got a good number of measured bleeding events, and that's a shortcut for statistical model to increase the positive predictive value. A lot of work to confirm and validate this result is required, absolutely. But I believe that we have definitely made a step in the right direction here. So the take-home messages are all here. The difference in elasticity or shear modulus is better than amplitude to estimate the platelet contribution to the clot strength. The Quantra device that directly assesses the shear modulus of the clot and its platelet component incorporates both platelet count and function and discriminates measure bleeding in cardiac surgery with good positive and negative predictive values. I believe that we need for sure further research to validate the clinical application of these findings. But I can say that we can't wait to do this research. And thank you for your attention.